All right. Welcome to the Evolution of Eating Disorder Treatment, Exploring the Past, Looking Toward the Future. My name is Lydia Rhino. I'm the Program Director at the Eating Disorder Foundation, and I am so glad to see everyone here tonight. Today's workshop is brought to you in collaboration with the Eating Disorder Foundation and Within Health. I'd like to take a moment to share a little bit about the Eating Disorder Foundation. We are a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based organization that is now serving individuals and families both nationally and internationally. I want to thank anyone who made a donation upon registration this evening. We were able to provide free services because of the generosity of our community. I will also add the donation link in the chat if you wish to contribute. If anyone has any questions for our presenter this evening, I invite you to use the chat feature to communicate with myself, Mandy, and Wendy directly throughout the workshop. The chat is kept confidential, so the whole community won't be able to see your questions. It will just come to the three of us. And we will be able to save time at the end for a question and answer. And if we are not able to reach your questions throughout the presentation, I would like to invite you to please send them to Mandy. She's going to put her email address in the chat to make sure that we can get those questions sent to Wendy, as she loves to be able to respond to those and keep the communication going. So I want to invite folks to send messages throughout the presentation, but also to know that that resource is there as well. We will not be sharing the PowerPoint from this evening. However, we are recording tonight and we will send the recording as soon as possible. Again, that should be up within 48 hours. And now I'd like to turn it over to Mandy to say a few words about Within Health's program and introduce our speaker for the evening.
Thank you, Lydia, and thank you to the Eating Disorder Foundation for having us. We're so excited to be here. My name is Mandy Rector, and I am local. I live in actually Loveland, but I'm born and raised here in Colorado. And I'm so glad to be here and grateful for all of you for joining us tonight. I just wanted to do a quick introduction, a little bit about Within Health. Within Health is a physician-led healthcare organization that's all about innovation, compassion, and integrity. Within Health launched in 2021, and we offer an enhanced remote PHP and IOP level of care, treating ages 13 and up, and we're licensed to treat in 39 states and counting. It is my pleasure to introduce you to Dr. Wendy Oliver-Pyatt. Wendy is a world-leading expert on treating eating disorders. With more than 25 years of clinical experience, she has developed 5 distinctive treatment programs, all grounded on strong biopsychosocial foundation and incorporating intensive psychotherapy with behavioral health foundations and high medical standards. Wendy has developed a unique treatment approach that delves into the underlying issues that place the person at risk for mental health conditions and eating disorders and lead to healing, health, and inner peace. Wendy received her specialty training at New York University, Bellevue Hospital in New York City. She has also held faculty positions at New York University, Albert Einstein School of Medicine, and University of Nevada School of Medicine. Wendy is board certified by the American Board of Psychiatry and Neurology and is both adult and addiction psychiatrist. She is the author of 2 books, most recently Questions and Answers on Binge Eating Disorder, a guide for clinicians. She is a fellow of the Academy for Eating Disorders and the International Association of Eating Disorder Professionals, and most recently was accepted as a fellow of the American Psychiatric of APA Association. She has received senatorial recognition for her commitment to the mental health treatment community, and I'm thrilled that she has a wonderful presentation for you all. And so I'll turn it over to you, Wendy.
Thank you, guys. Thank you all for being here. Thanks for taking time out of your life after work or after the long day that we've gone through together so far. I really just want to start by, I really mean it. I know everybody's lives are so busy and people are stressed and a lot going on in our world. So thank you for taking this time to be together. And I'll do my very best to answer any and all questions either during the talk or in follow-up. You can send messages to Mandy. As I was telling Mandy and letting you know, I do love getting questions. It helps me learn and helps me know what you're thinking about and wondering about as I go along. So I just want to say that that really benefits me too. What is happening here? One second. My slides are not advancing. One sec. I'll be darned. One second, guys. This is very strange. It's making funny sounds. Great. I'll do it from here. Okay. Sorry. Usually I do it from my keyboard and I've never had to do it from there. Anyway, the reason I wanted to do this talk is because over the 20 plus years of doing this work, so many things have changed. But I didn't really realize that until one day I was on the Facebook page and somebody said, does anybody know of any Hayes providers? And all these people were like, I'm Hayes, I'm Hayes. All these people were, seeing how they were Hayes treaters, providers. And I was just really taken aback because when I first started in the field really early on, I really considered myself what is now called a Hayes provider. The way I was approaching care was what we would call Hayes, but there was no name for it. It wasn't talked about. And then when Hayes came out in the field, at first we were really kind of shunned and people kind of rolled our eyes. And I don't know how many of you guys remember that time when we started the Binge Eating Disorder Association and we really put forth the principles of Hayes, and we really began to talk about weight stigma, and we started Weight Stigma Awareness Week, and we went through a lot of crap for that, and we were kind of treated like we were little crazies. And it was sort of interesting for me to see how the field changed and started to really appreciate that model. And people were really saying, yes, I'm Hayes. And I just thought, wow, things have changed. And then I started to realize, wow, so much has changed. And I thought, it's good to look back and say, well, what's changed? And also realizing that things that people thought were the thing, or things that people didn't know at all that weren't yet evidence-based, therefore not getting as much credit, if you will. It really made me realize that we've got to always remember that we never really have all the answers, and we should constantly be evolving and questioning ourselves and looking back and learning from the past, and then looking forward and be expecting ourselves to have this change within our field. So to know where we're going, it's helpful to know where we've been. It's helpful to reckon with the reality that we don't have all the answers. What is not yet evidence-based may be something we intuitively knew. That's what we're free. I had a lot of intuition from my own lived experience, but it wasn't evidence-based. Overemphasis on what is evidence-based in the moment and rigid views on what is defined as effective treatment could be very harmful. Actually, Susan David is a clinical psychologist, wrote a book, and she said, rigidity in the face of complexity is toxic. It's a great quote, and it's really, really true. And then one of my kind of big principles from this is that the value of lived experience really cannot be overstated. So this is an update of a talk that I started doing a couple years ago, talking about some breakthroughs, and it's continued to evolve as I've added concepts to that, and we've began to have this conversation about carceral care, and some of the discussion around that at the Meta conference was really important, and I want to talk a little bit about that. We've seen a lot more treatment trauma as well, so we're going to talk a little bit about that. Now, going back to basics and going back to the past, I think it's important to pay respect to and really think about the principle brought forth by Hilda Bruck, who was a pioneer in the treatment of eating disorders. She came over from Germany, escaping Hitler and the Nazis, and she did not develop the biopsychosocial model. That was another psychiatrist who had brought that idea into conceptualization, but she really revived it in her work with eating disorder patients. She recognized the biopsychosocial foundation. And wow, I mean, there really is, I think, no other condition that has such a vivid example of the need for the biopsychosocial foundation. So this is a part of the past that I believe needs to be more alive in the present. And I think we really try to make it alive in our programs, but thinking in an integrated way using a biopsychosocial, or you can also call it biopsychosocial spiritual foundation. This is how you make sure you're leaving no stone unturned. The biopsychosocial foundation applies to all kinds of illnesses, mental health and other medical illnesses. take for example, diabetes. There's a biopsychosocial component of that, whether the person's type 1, type 2. Exposure to certain things may increase the risk of diabetes. Psychosocial variables, if a person has diabetes, biological variables that place the person at risk for diabetes. So using a biopsychosocial model is really helpful in both looking at the etiology of condition and then, very importantly, the treatment planning. So when we were in psychiatry residency, we used to have to do case write-ups, and we had to create a whole biopsychosocial treatment plan. And that's something that I really place the emphasis on in my care. And using, yes, it's about the acute treatment, but the psychosocial variables, the family systems, the community systems, the role expectations the persons have, the vocational, the academic, making sure that's all aligned with like the human being that's before us. And as I've kind of marched along in the field too, there's been times when I wasn't always met with, so much welcome, and I was challenged and questioned in certain ways. And the thing I always held on to was this idea from Rosa Parks, this wonderful quote that you must not be fearful of what you're doing when it's right. And I really believe that my lived experience like helped me probably like as much, if not anything, as much as any book ever helped me, I think. So anyways, so here's the things that we're going to try to get through tonight. There's this idea of treatment becoming trauma informed. There's epigenetics, psychedelic, lived experience, harm reduction, cursal treatment. None of that was talked about in 2003. The emergence of health at every size, weight stigma awareness, then all the concepts of diversity and inclusion, talk a tiny bit about DBT and the model there and why I think it's so important to think about. And then, what we're doing now, which is remote treatment, and that's definitely, a breakthrough, we think, and we do it a little differently or a lot differently than any other program. And I believe for very good reason. And I do think that remote treatment gets sort of a bad rap because people just think remote treatment is remote treatment is remote treatment. And there's just like in person, brick and mortar, huge variations of like approach, treatment, fidelity to foundations, training of staff. There's a huge variation in what's available for remote treatment, huge, and it has very big implications. So this concept of the lived experience, I just think is important to talk about because really when you look at all these breakthroughs that we're going to talk about, lived experience, kernels of lived experience was within those breakthroughs. So they might have become evidence-based later, but actually human experience, lived experience is actually evidence. So this idea of evidence-based treatment, when I was like earlier in my career, I always thought, oh, evidence means double-blind, placebo-controlled studies. And over time, I have learned that evidence is really, now we understand it as like a three-legged stool. So evidence does include those studies that we talk about, the hard evidence, if you will, but also lived experience is a form of evidence, and also patient preference and clinician experience is a part of that. So really broadening the definition of what evidence is, and I think that through my lived experience, there has been sort of the pathway, it has helped me a lot go in the direction of what I call empathic attunement to the whole person. That's what I think we really are aiming for in our work. And that's because this condition is a disorder that involves the self and fragmentation of the self. And it's the attunement and connection between the patient and the provider that is really the kernel for all of the healing that we do at the end of the day, in my view. So notable game changers that I'll touch on are Timothy Bruton, Shavis Turner, San Chang, and Marsha Linehan. And those are related to Tim as trauma being allowed into treatment. So back in the days when I first had my first treatment center, we were not supposed to address trauma while the patients were with us. So the insurance companies put a lot of pressure on us and said, no, you can't do the trauma work. They thought the patient would just like never get out of treatment. And so that fueled a lot of recycling of patients. And it still is a problem because really good trauma treatment should happen and when people are in the safety of higher levels of care. But insurance companies frowned upon that. Tim Bruton did so much research, the insurance companies didn't have a choice. So thank you to Tim. I really respect his work. Then the binge eating disorder piece was really important. It just kept getting pushed out of the DSM, and Shavice Turner worked really hard to get that into the DSM-5. Weight stigma started to get spoken about. When we started Weight Stigma Awareness Week, it was really not spoken about. And I think weight stigma is at the core of all forms of eating disorder. And maybe not ARFID, but in certainly all forms of eating disorders, internalized shame and weight stigma is a part of it. And it's one of those core things. It's the place where a paradigm shift needs to happen in treatment to really break free of that. And then the concept of health of every size became accepted. Diversity inclusion began to take hold. We started to really do better. I didn't even know, I'm very ashamed to say, I didn't even know when I would get calls for transgender woman, like, could I treat the person in my all women program? Like, I didn't know any better. And it's horrible to think of what people have endured. And then of course, DBT. So I'm going to go through this pretty quickly, but I was already mentioning that so many forms of trauma were co-occurring. 80% of people who go into higher levels of care have trauma, and it can be a chronic, everything from minority trauma, chronically invalidating environment, what we call PTSD, which we'll talk about. And it's really been a breakthrough. Yay. And now everybody's talking about trauma informed, and so it's really a great thing to see, but it wasn't always that way. And then just really quickly, I like to really help people see how the eating disorder is like intertwined with trauma. So avoidance as a PTSD symptom, and there's a sort of an eating disorder version of avoidance. So when you see certain eating disorder behaviors, such as restriction of anorexia nervosa, the restriction of emotion, that I'm fine, the disconnection from food and appetite is sort of a disconnection of the source of life. And that's really what avoidance in PTSD is about, is just the overwhelming nature of the trauma leading to this like sense of foreshortened future and apathy and loss of enjoyment. And so there's a way that the eating disorder behavior of restriction, and it can be in all, you can see restriction, of course, in all forms of eating disorder and binge eating disorder as well. And really, when you see that restriction, to think of it as a PTSD symptom as well, that's related to avoidance. And so that gives you a little bit more to work with than just only focusing on the food. If you listen to the behavior of the eating disorder, what else is it saying beyond what the behavior with food is saying? And then arousal in the eating disorder version is the exaggeration, the feeling of fullness, just like the arousal from trauma. And I call it a faulty alarm system, where the person with the faulty alarm system of the eating disorder has high arousal to, for example, eating a sandwich. So they get a red alert signal, alarm going off, and then they have sort of no response to hunger and starvation. They're, oh, that's fine. So it's like the wiring system is all kind of off. So I call it a faulty alarm system. And so really like exploring that with patients and exploring and looking at how the arousal with relation to food could also mask arousal that is in general present as related to trauma. So again, speaking the language, looking beyond the symptom and being curious about what the symptom is really representing as a therapeutic opportunity. And then reliving, as somebody is just constantly, their brain is invaded with thoughts of food, it's not going to be as connected to trauma, overt and covert trauma. And time again, I've experienced this clinically, is as we in higher levels of care sometimes manage some of the food behaviors, that is when the person begins to have memories, sometimes that they didn't even know existed, and really seeing the intensity of symptoms of the eating disorder as functioning to protect the self from the actual trauma or traumas themselves. So as we're just, running around chasing eating disorder symptoms, what are we not? We what are we not doing? So I always talk to the teams about watch out for symptom chasing. When you're symptom chasing, you're really missing something for sure. And so sometimes you do have to really address the symptoms. So I'll do things, you know, in case this is helpful, like I'll do things in treatment, but like we're going to talk about some of this behavior over here and then sort of direct the sessions to, we're going to actually do some other stuff today too. But following a DBT model, you can't just let people do destructive behaviors out without addressing it. But if that's all you're doing, you're not going to have the time in your sessions to do any of this other work, and being very intentional in that way. And then CPTSD finally made it into the ICD-11 in 2022. It's not in the DSM. So it's kind of tied in with childhood neglect, emotional invalidation, and is, I think, sort of in some ways really is a crossover with what we call borderline personality disorder, which I don't call it borderline personality disorder because I don't think it's a disorder. I think it's a way of it's an adaptation to an environment where there's a lot of different kinds of invalidation or neglect. So I don't like calling it a disorder because that pathologizes the patient who's really actually reacting to an environment that didn't meet their needs. So just my little 2 cents worth there. I don't like that word. I don't like that language. So, but what can cause it is all sorts of different things. But I do think being large in a diet culture, weight stigmatized world is also a form of trauma, undoubtedly. Racism, bullying. And so with CPTSD, you do get the avoidance, hyperarousal, and reliving like in PTSD, but in different ways. But there is this, what we call DSO, disturbance in self-organization. So a person with PTSD might have all the things that you see in classical CPTSD, but with CPTSD, you see the self-organization issues, which is tied in with a negative self-view, difficulties with relations, difficulty controlling emotions, which is again where you sometimes see the relationships, emotional dysregulation that you see in borderline personality disorder. And there's really big, very important treatment implications. And I think this is where it comes back to the relationship, if you will, as cliche as it sounds, a corrective emotional experience, the importance of attunement, the importance of what I call love and boundaries and sort of shaping the behavior of the person through sharing of yourself. And I love self-psychology as a foundation for that. But really understanding CPTSD is very important versus PTSD because this disturbance of self-organization is really where we've got to pay a lot of attention to with our eating disorder patients who also have a disturbance in the way they see themselves so often. And then childhood emotional neglect is a really important part of CPTSD. So moving on to some other aspects of trauma, and really a lot of this stuff all does go back to trauma. Back in the early days of my career, people did not know what epigenetics was. So I think just knowing what epigenetics is as a provider is important, and we understand. And I think, you know, I don't know this audience, so sometimes I don't know, well, does everybody know what epigenetics is, or does, you know, I just don't know. So I'm like, I could be wasting your time and explaining it, and I don't want to waste time. So basically what epigenetics really has proven out is that rather than just Darwinian evolution, which is like this very slow change, survival of the fittest, and that really is tied in with DNA changes, which is changes in the amino acid sequencing. Deoxyribonucleic acid is the chain of amino acids bound together by proteins in every single cell of our body. The DNA chain itself is the same in whether it's a neuron or whether it's a cardiac cell, skin cell, same DNA, but gets expressed in different ways to create our cells and our organ systems. And Darwinian evolution says that the DNA changes as a response to environment, which is a very slow process. When epigenetics came around, this was like blowing my mind. My daughter was in 9th grade and she ran into this in her 9th grade biology book. And I was like, what is this? Because this shows you how crazy the science can be, right? When I was in college, I was a biopsych major, and everybody's like, Darwinian evolution, that's the way it is, and nothing else can be the case. And then my daughter's in, fast forward, whatever it was, 28 years or no, 38 years or something. Um, she's learning about epigenetics. I was like, what the heck is this? So epigenetics really is the rapid change, not in the DNA, but the way the DNA is expressed. And so certain things can happen in our environment that cause methylation, histone formation on the DNA itself, which changes the way the DNA behaves. And the way it behaves really is in response to stress. That has to do with immune responses, arousal, cortisol, and all of these things that are happening epigenetically are in relation to stress and trauma. And now we know that the way my dad's trauma affected his DNA is actually passed on to me. So that is where intergenerational trauma has a true biopsychosocial foundation. So looking into intergenerational trauma, epigenetics and PTSD is very important, because when you're treating the patient with an eating disorder and co-occurring trauma, you're also having to remember there's an intergenerational component necessarily, and the trauma of their ancestors are a part of the trauma you're treating. And that's why a complete picture of the patient, understanding the psychosocial environment they're in, because if I'm parented by somebody who's endured trauma, not only is the way my DNA behaves different, I've also been around somebody who's been through trauma, which is a part of now my trauma, of course. So I know we're always talking about trauma nowadays, which is important, but I think when we think about trauma, when you're sitting there with a patient, I like to remember to think about their ancestors, think about their immediate environment as well. But the epigenetics really has some change in our field and understanding it. And so an analysis of 14,000 genes in the PTSD sufferers' blood samples showed that these, compared to people without PTSD, these kind of epigenetic changes were seen to 6 to 7 times more likely. I mean, there's no doubt about it. Adversive childhood experiences also cause these epigenetic modifications that are really just, again, not changes in the DNA, but in changes in the way the DNA is behaving, which increases PTSD, increases rates of suicidality. And then there's other metabolic effects overall leading to lower life expectancy. This is just an ACE pyramid, and it shows how these ACE experiences affect disrupted neurodevelopment. And I have a slide that actually shows the way the brain actually changes. There's this experience called pruning, which has to do with how the synapses are formed, and there's this sort of organization that happens. And in kids with adversive childhood experiences, the proper pruning structure hasn't happened. So there is actually a neurodevelopmental component to this. And so this trauma has really shown up in our society, intergenerational trauma tied to sizeism, racism, classism, the whole kit and caboodle. And then, as we all know, as we're practitioners, I think the way that it manifests is in so many different ways. And it's no wonder this is such a hard condition to treat then, right? So Timothy Brereton, hat is off to him for trauma, allowed into treatment. I'm a big believer in EMDR, which I'll talk a little bit about that, but new interventions becoming standardized. These are just some of the many, many, many publications that Tim was involved in. So my hat is off to that. The next thing was the way BMI came in. Weight and shape were the focus of health. BED wasn't recognized in the DSM. Most importantly, BED patients often, and still are, put on restrictive meal plans. Clinicians don't understand BED as a restrictive condition. I'm working on that with some of my research to prove that out. So people that are in larger bodies don't get traumatized by be putting on starvation diets and treatment, which is horrible. And Shavice Turner, my dear friend, was a big part of getting BED in the DSM. And we started Weight Stigma Awareness Week, which is in September, and Shavice and I are the co-hosts of it. And within sponsors that, we really invite your involvement with that. It's a very open time, and we really try to do things. What my goal is to have weight stigma be common language, and just like racism is known for what it is, that weight stigma is also known in that way. And then I talked a little bit about the harm of underfeeding people in treatment is all tied into weight stigma. Diversity and inclusion is a big breakthrough for us. San Cheng was very involved in this, and they wrote some books that I think were game changers. Clinician's Guide to Gender Affirming Care is a very important book that I think has really transformed our awareness altogether, not just with transgender, but with all the need for inclusivity in care in general, which was not really attended to when I was first in the field. Recognizing the impact of racism, so just working with minority populations, knowing they have experienced racism, period, and how is that affecting their development and their sense of security and safety within their communities and their family systems and work environments. That's got to be a part of a good biopsychosocial foundation. Understanding why racism exists and what's happening around folks, I think is a big, I'm very interested in this subject because it's really, as somebody who's a child of a Holocaust survivor, you want to believe that there's evolution and healing and progress, and then you kind of see how things cycle back, human behavior. And so also helping patients who experience racism understand the roots of racism so they can, instead of thinking of themselves as defective or less than, to look at what's the roots. Well, lack of compassion, personal insecurity, projection of flaws, poor mental health, like helping people understand, well, where does it come from? It really isn't about the person, it's about who is inflicting the racism. These are some of the cores of where it comes from. Racial stigmatization actually does change the blame, though. The brain actually changes the brain. That's why, again, biopsychosocial, it's all together. Your brain changes, and then psychosocial, like what comes first, the chicken or the egg, right? So we've started to do better. We have a long way to go. The fourth is the Marsha Linehan, who's the developer of DBT. When I first started believe it or not, I mean, this just shows my age. Nobody knew what DBT was. My first treatment center was in 2003. I was lucky enough to be near the University of Nevada, Reno. So I ended up hiring a clinical psychologist that trained with Dr. Frusetti, who had trained with Marsha Linehan. He moved from Washington to Nevada. I end up with Alan Frusetti's protege in my treatment center. And I was like, holy crap, this is good stuff. But nobody knew about it. But Dr. Linehan started DBT and really started connecting behavior with psychodynamic understanding. Because before that, it was like behavior and psychodynamic understanding were like sort of separate. There was like the dynamic people, the behavioralists, but she really developed, which I love this so much, the idea that the symptoms make sense. Wow, that's a huge, huge thing. Symptoms make sense. And one of the core principles that I think is yummy, yummy, yummy is the concept of validating the valid and invalidating the invalid. And in self-psychology, we use this concept that validation firms up the self. Now, validation doesn't mean enabling, it just means validating the emotion, and really learning all the types of validation that are available to us is very important. And this idea that there's an emotion mind and wise mind that can coexist, and really debunking that all or nothing thinking that was sort of psychodynamic thinking or psychoanalytic thinking of like, oh, look at this defective self, and realizing that we have all these little parts, and that's sort of alive in IFS now too. And I love that self-psychology and DBT have a link to the therapist being truly supportive while drawing on the patient's strength. So I get a lot into self-psychology, which we aren't going to have time for. But there are some connections, and that's what's kind of cool. Really old school self-psychology. I've done talks on it, and some of the older clinicians, they're like, I can't believe you're talking about self-psychology. I remember that in 1972. But there are some connections with DBT. But what's really cool about DBT that I think is important in our field and that I'm very excited about for within is that Marsha speaks about these different stages of healing, which are very important: getting behavior under control, focusing on emotional experiencing, and then solving the problems of everyday life and achieving transcendence and building the capacity for joy. a lot of treatment is really about stage 1, maybe stage 2. Get the patient into a program, tune them up, get rid of the behavior, weight restore, stop purging, don't ever exercise, and out the door you go. And that doesn't work because you're not going through all, thank you, Dr. Marshall Linehan, like there's further healing that has to happen. And that is one reason why I love what we're doing within health, because we're helping people solve the problems of everyday living. We're in their life with them. We are with their families. We are with them in the grocery store. We're in their kitchen. We're with them after they broke up with the boyfriend in our, in our family living room or through our chat. So we're available to patients for up to 10 p.m., up to 12 hours. And we've changed the way, I'll say disrupted the way treatment is done, because we're in their home and we're with them along their side to help them solve the problems of everyday living and leading towards transcendence, building that capacity for joy. So everybody that comes through our program, before their discharge, we have to see a lot of work done on stages 3 and 4, not just stage 1, maybe stage 2. So this segment of the talks just talks about how the stages of DBT are tied in with what we see with eating disorder recovery. I'm not going to spend a lot of time on this, but I just wanted to hit the motivation. So in stage 1, a lot of times the motivation is really just external controls, like your family's making you go to treatment. So we got to move through that. Like, people don't generalize behavior outside of treatment if their motivation is just externally controlled. So in stage 2, the person's starting to focus on emotional experiencing, and that's when they start to develop some curiosity about their own symptoms. They're still very program dependent to avoid slippage, but the person can start to recognize, oh, there's that wise mind. That's where internal regulation can start to come from. So there's a lot of reinforcement from the team and the family, but the person's starting to get those sparks. And then in stage 3, the person's really on an eating disorder point of view, they're starting to really get through things. They're starting to get some joy in autonomy. The wise mind's really connected to the true self and managing the relationship. The patient's able to tolerate without reacting. So that's a really exciting stage that we get really excited about. And they start to have some self-motivation to recover, and they start to have episodic joy and peace and contentment. But they're still vulnerable in a way, and they haven't really locked it in all the way. They can still, if triggered, slip back into former behavior. Whereas we want to get all the way through it where the person can be consistently flexible and adaptable. And when even stressed, that they are able to not return to their eating disorder. I always say with this stage, there's stages to the stages. Like, of course, I can't keep somebody in treatment, and I know what I want to until they've like reached pure transcendence. But getting to a place where even when something really hard happens, they can talk about it, and they come into a session. They did, fail a class. They did have a fight with their parent. They did lose their job, and they didn't go into their behavior. They called us. They had a session. They processed it. The other part that I just want to add, that this is my throw in and that I don't think gets enough credit, and it's tied in with trauma and DBT, is EMDR. So EMDR was also a breakthrough that wasn't used until more recently, and it's an underutilized modality. It is a proven, very validated form of helping people heal, and it was a breakthrough by Dr. Francine Shapiro, who had lived experience of trauma. She had a sibling that died of cancer, and she was walking through a park one day, and she was very traumatized, and her eye gaze was going back and forth looking at this park, and she noticed that it had calmed her nervous system down. That park experience, Francine writes about that it was the genesis of this, what became EMDR. What's so exciting about EMDR is it respects body wisdom, it's healing without re-traumatization, restores a sense of control, and validates lived experience beyond words. It's very exciting. Psychedelics, trauma and depression. What's very exciting about psychedelics is that it can really help with those big paradigm shifts where you're, instead of self-hatred, moving into self-compassion. So there's ways that the mind opens up and sees things from a different perspective, and there's neuroplasticity effects as well. So it's truly a groundbreaking time in our field. And all these years that I've been in the field of psychiatry, there's been no drug that ever just took my breath away of like, wow, a big change is happening. But it's not for everybody, but I see it as something that's really powerful and has a lot of potential. And it really has a biological effect with especially the neuroplasticity, and then this psychodynamic effect, which is why I think the ketamine assisted therapy is so important, not just ketamine or not just psychedelics alone, but these are just some of the studies. Some of you may know that ketamine can be very effective for suicidal thoughts and depression. So this is an exciting time. There is growing interest now for all of these psychedelics and ketamine for the treatment of eating disorders, for treatment-resistant cases with chronic anorexia nervosa, BED, comorbid, especially with comorbid mood and PTSD symptoms. The ketamine is an NMDA antagonist that promotes neuroplasticity and rapid mood improvement when it does work. And then the psychedelics are 5-HT2A agonists, facilitating altered consciousness and self-exploration. A little sharing. When this sort of came about, I was able to get a few trials of just the licensure of ketamine because I wanted to really understand what the heck is going on here. And what I try to share with patients when I talk about it is like it really brought me in touch with a deep sense of compassion for myself and for other people. So if I was in maybe a conflict with somebody, or I wasn't sure what to do about a certain situation, maybe whether it might have been a patient, might have been an interpersonal thing, it really got me in touch with compassion, and it helped me just get anchored, like, hey, whatever I do is going to come from compassion versus reaction. And that was really exciting to me because it helped me understand certain things, who I wanted to be in certain situations and with certain complex situations that I know we all face. So ketamine case studies showing reduction in compulsivity and depressive symptoms, body image and trauma symptoms improvement with psilocybin and MDA. But there is caution, small sample size, lack of controls. It's really hard to get a control group, right? Because it's like we kind of know if you did or didn't take the MNT, the psilocybin, and then the potential for dissociation and appetite suppression is very real. There's a lot of opportunities with these medications. Cognitive flexibility is another big one. We see this cognitive rigidity and where the neuroplasticity comes in versus the self-compassion and how that works together is really, really, really fascinating. I think as a person can get into the self-compassion, that can really reduce shame, and that reduction of shame can actually foster embodiment. So it's a very big, experience for people that has tremendous implications, because so many of the things that these meds can do really address a lot of the core aspects of eating disorders. I think ethical and clinical guidelines that I've wanted to share, that I've just sort of patient selection is really important. I think at therapeutic support and oversight, I don't believe in, just somebody doing ketamine on their own. I believe in the holistic care, an adjunctive tool that is within the framework of a multidisciplinary approach, and being very careful about safety. And then just I try to make sure when people leave a talk, like there's something to go from. So I wanted to kind of talk about, okay, if you're sitting there and you have a patient, you're thinking about what should I do? Is this person a candidate? They do have to have medical and psychiatric stability. I wouldn't put somebody really low weight, orthostatic vital signs, suicidal, manic, active substance abuse, psychosis. That's a no. When there is significant trauma, OCD, or severe depression, okay, that is just not getting better. That's a situation to think about, but not if they're active substance abuse, psychosis, and things of that nature. Or I would even say really unstable living environment, that sort of thing. And I really believe in these ketamine-assisted psychotherapy. I've spoken to people that have done both, and they just say, holy cow, when you're doing the ketamine-assisted psychotherapy, the changes are just so fast and intense because people can really come in with some intentions around the experience, and doing that process with another human being, very exciting experiences. And I think it's important that's not standalone. Making sure informed consent happens, integration is important, and then staying in touch with emerging research. Lived experience is just a part of all of this. And I just want to share that this is really sad what I'm about to share, and then we'll wrap up after this. But what was once considered the best treatment, and this was evidence-based. I've had so many patients have trauma in what are considered evidence-based programs. This is a real word account of somebody that I know very well and I treated, who had very serious eating disorder, and this was her experience of early treatment. I just want to share it. She said, I actually spent a pretty long time trying to avoid the memories of my early treatment. I was treated in a locked psychiatric unit designated for eating disorder patients beginning in 1995. I felt subhuman at that point. I felt like a caged animal who was being tortured, and maybe one that had done something terrible that deserved that, because her brain couldn't understand it, so she blamed herself. I must deserve this. Endless amounts of terrifying, humiliating experiences, and yet people were flown from all over different parts of the country to receive this amazing evidence-based treatment in this prestigious hospital that I won't name. Well known, though. I had also learned that the treatment professionals were the enemy. These were people against me, and they could not be trusted, and they would do things to hurt me. I honestly think the biggest things that were missing in those early years were compassion and humanity, being treated like a human being. And she said, I try not to think too much in the pain. I try not to think too much about how many lives were needlessly lost because of this type of thinking of this supposedly evidence-based practice medicine. So, this is really painful to think of these concepts. And now you hear a lot of discussion now about carceral care and being anti-carceral. And I was really kind of like, what do I do with that? Because I'm I'm kind of nice, but I'm also kind of strict, I guess you could say, as a provider. I really have some principles, I think, and yet I'm flexible. So it's kind of weird. But when I heard about all this anti-carceral stuff, I thought, well, am I carceral because I make people, I have people stay fully till fully weight restored, and I want to make sure they're through stage 3 and 4, or if they haven't managed certain things with food, then they don't get to self-portion. So I have like sort of principles of this, and it was really great because Molly Robbins, who works for me, gave a talk at Meta, and she talked about she called this concept of clinical nihilism, where you just give up on patients, and sort of like how the anti-carceral movement, if you will, kind of got interwoven with this, what feels to her. And she identified this clinical nihilism where, okay, you're not being carceral, but you're just sort of giving up on patients. So in this whole harm reduction place, anti-carceral place, are we also then not holding the bar high enough? So I think this is an area that we need to keep talking about. Molly got a standing ovation. And so I kind of named this, is it carceral care versus compassionate boundaries? Because I was feeling a little bit like unsure, like, am I carceral, And so I decided, no, you have compassionate boundaries, Wendy. So how do we figure out harm reduction versus attuned boundaries? This is some of the areas I think that we're at right now in the field. And there's got to be this place where we honor autonomy, reduce shame, increase trust, but we also create safety and accountability, and we build structure. And that's, I think, how we want to create conditions for change, and that we want to move from just compliance to connection. So in the past, it was just symptom eradication, get out. And now what my paradigm that I want to be in is humanistic trauma-informed harm reduction, but also shifting from compliance to connection to motivation. That's weight inclusive and anti-stigma framework. So what's actually, anti-carceral could be enable harm. So, oh, I don't want to be I want to be anti-carceral. So, okay, you can go off to school and you're, underweight, purging, unstable vitals, because I don't want to be carceral, and family is funding college and they're not funding treatment, to give an example. So I think holding compassionate boundaries is not punishment, it's an act of deep care. And really helping families have a voice and be able to name how they're feeling and have that be a part of treatment, family and loved ones, is also important. Really believe family and loved ones could be friends, significant others, cousins, pastors, rabbis, all of that. And then using our natural consequences versus artificial consequences is very important, which is artificial consequences is punishment. Like you don't complete your meal, you can't talk on the phone. I'm not going to talk about self-psychology, but self-psychology really, along with DBT and all these modalities, really put the focus is on nurturing the connection, and through that, the self grows, evolves, and thrives. And you can actually build connection while integrating natural consequences. That's what really good treatment does. I can be close to you and I can build in natural consequences to our relationship. So I am going to go into our last little segment here, which is the breakthrough of remote treatment. So we know that during the pandemic, brick and mortars went virtual due to the pandemic. Everything sort of went Zoom. We had no choice. Now we have new modalities of care that there's a couple of programs, a few programs that are intentionally home-based. One of them was sort of oriented towards FBT. And then I'm just going to talk about, there's one that's sort of oriented towards FBT, and then ours is actually oriented towards some of the things I'm talking about. It also utilizes my past work in assertive community treatment that's sort of integrated with how we get through all those stages that Linehan talks about. And talk about assertive community treatment another time, but it really involves psychosocial part of it. So some things that are really cool about remote is that it's easier to enter treatment. You don't have to like go away to be in treatment. You're in treatment in your home, so accessibility is increased. So more underserved populations get to be a part of things. Well, I think, you can interrupt the progression earlier. The patient doesn't have to hit such a low to go away because it's easier to get in. You don't have to sacrifice as much. You can have more family involvement. They're right there. Softer landing from brick and mortar to back to home, a lot more support around there. So you don't have to go from 24-hour care to just you're on your own. You don't have to transfer the benefit of brick and mortar into home. So there's so many things. You can have cohesive groups with certain groups of patients. Like we have an RFID group with like 17 people with RFID. Like you never get that in brick and mortar male group or mature adults. And these kind of cohesive groups can facilitate belonging, purpose, and recovery-oriented behavior. One nice thing is you don't have to like go back and forth the person about going home because they're home. So that's like nice. The disadvantages, sometimes you just can't stop the behavior. So any remote program, any program that says, oh, I can take care of all patients other than those in the hospital, no, that doesn't exist. There's no one treatment for everybody. There's different modalities of treatment in remote, just like there's different modalities of treatment in brick and mortar. And there's no one-stop shopping for all patients. And anybody that tells you there's one-stop shopping and there's only one evidence-based type of treatment, that's just not true. So we do an enhanced IOP PHP. It is a level of care that previously never existed, with a huge amount of flexibility. I really believe in high frequency of individual therapy, high frequency of contact with providers, individual sessions. I believe that nursing needs to be a part of treatment because it's a biopsychosocial condition, and education is a part of it, helping people like, when we do blind weights and vital signs, like helping people understand their body with a medical team that is helping people like really account for the medical aspect and incorporate that into their understanding of an eating disorder. Because again, it's a biopsychosocial condition. I really believe in the thing that we do, which is we do bring the patient's meals into the home. I don't believe that people at the PHP level of care or who are sicker at IOP level of care ought to be bringing their own meals, because I think if you need IOP or P3 level of care, you're probably going to bring celery and not mac and cheese. So I really think if you haven't eaten pizza and treatment, you know, and you don't eat pizza on your own, then when you leave treatment, you're not going to eat pizza. And that's not treatment. That's not true. I'll just say that's not treatment. And we do have outcome data now that shows that this modality of care, again, it's different than just general virtual treatment. That's just, okay, I've got Zoom sessions, which is not, I'm not dissing that. I'm just saying I've decided that I'm going to own it. Like, there is no more comprehensive eating disorder treatment that's available remotely in the world. We've done it this way, not to overdo it, but we just feel this is what's needed to do it. So we've got this very intensive model of being available for up to 12 hours for patients. So a lot of contact in between sessions. So we're in their real life where all the stressors and triggers are. So we can't just expect them to only have struggles during our 3 hours of IOP or 6 hours of PHP. So we make a very wide range of time availability and lots of checking on patients, lots of family work, lots of exposure therapy across those continuums of what Linehan talks about. So we're really seeing wonderful outcomes that are sustained post-discharge, where you have free alumni and are doing post-discharge assessment. I probably sound like a within, show right now. I apologize, but I'm very excited about what we're doing. Mostly, I think it's a testament to our patients who, when they are given good treatment, good therapy, love and boundaries, accountability, thoughtful care, intentional care, they can do it. People can get better from very low body weights in their home. Does that mean everybody should be in this care? No. We send about 10% of our patients into a brick and mortar. We get a lot of people that step down from acute that will not go to a residential. We will take them if we can, and we work with them to get them to go to a residential. And I think of that as a success. So we really feel like we're making a difference, and we're excited about it, and we're expanding accessibility of high quality care. And we're very excited about it. And we appreciate the chance that we got to share this with you. And we consider it that it's a reimagining of eating disorder care with our programming. And we're very, very excited about this partnership, and always happy to talk with you about any patient that you may have. These are just some of the things that I've been talking about. And I do want to say the last thing. I also want to say, we hear this word recovering, and it's not really about recovering who the person once was. It's more about becoming who they were always meant to be. Because I had an eating disorder. I don't think I recovered. I don't think I went back to some other version of myself. I think I went forward to becoming the person I was more capable of becoming. So it's not really return to recovery. It's growth into a stronger, more integrated self, where the eating disorder no longer serves as a self-regulatory person, because the self has developed. My favorite quote, probably of Emerson, that I'll just share before we wind up: be not the slave of your own past. Plunge into the sublime seas, dive deep and swim far, so you shall come back with self-respect, with new power, with an advanced experience that shall explain and overlook the old. And I feel like I've been so lucky in our field to have what I feel like is an advanced experience, where I was able to have an eating disorder, which is, I still wouldn't redo. I still would not do that. I would still not be like, yay, let me have an eating disorder. But I think that I got to have this advanced experience, where I got to have this lived experience can be part of my life and work. And I really believe that eating disorder providers are incredible humans that are so giving and so compassionate and willing to lend their self in such deep and powerful ways. I've worked with every psychiatric condition you could possibly imagine, and there is no condition that is, I think, more challenging than working with eating disorders. But also the advanced experience that Emerson talked about is what I feel like I get to have because of my relationships with the patients and with clinicians that I get to work with, and meeting people like you that are doing this. Like, we give so much of ourselves And it's a powerful experience. And we also, you know, we go through a lot doing it. It's a hard thing we're doing. So we thank you for the time. I just realized I'm 2 minutes over, so I'm going to stop.
Wendy, you are just fabulous. Thank you so, so much for your time and your expertise and your wisdom. I can't think of a better person in our field to be speaking to this process of looking back at the history of the field and talking about all the newness that you're seeing and the new opportunities for change and growth that we have. I'm seriously so grateful for your time.
Oh, that's so sweet. I appreciate it. I love thinking about all this stuff. I really do.
I can tell it comes out so naturally for you, and that's just when I can tell like the passion is just like so present within that it just that it just comes through. So yeah, it's like a natural experience to listen to you speak to this.
Oh, thank you
I
so
have
much.
a question that came in that I would like to share with you. What are your thoughts on cranial brain mapping therapy?